Next speaker will be Charlie Aker, who has really done a lot of work on analyzing the outcomes associated with spinal cord ischemia, or the risk factors. And he will talk about the results and risk factors for spinal cord ischemia following open surgical repair.
I only have one financial disclosure, and that is my wife and collaborator for the last 30 years controls all my finances. If you're going to understand paraplegia risk in clinical series, it's very difficult to do it by looking at percentage of paraplegia. So in order to counteract this, we developed a paraplegia risk model so we could look at paraplegia risk more objectively in clinical series. And this allowed us to compute OE ratios and make the data more coherent. And if you look at this, this is paraplegia expressed in percent paraplegia in multiple series in about 6,000 patients. If you model that same group of patients, what you get is a straight line with that predicts 99% of the variation seen between these. So by counting for these clinical factors, extent of aortic replacement and clinical presentation, you can actually make clinical data coherent and have a much better understanding of what outcomes are. And with this, we're able to look at our own and others' clinical data a little more objectively to determine what things work and what don't. And what this showed us was when we were also able to discriminate between different techniques of repair, what this showed us is that assisted circulation alone, without adjuvants, but with intercostal reimplantation, was the same as cross-clamp patients, and this also was in about 6,000 patients in multiple series. So they had equivalent outcomes whether assisted circulation was used or not. And the OE ratios were comparable and not statistically different. When I came back from Houston after working a year with Dr. Crawford, we were certainly able to reproduce his results using his technique, but for us, that paraplegia rate was really too high. So we set about trying to improve it. The clinical data at the time, the clinical push at the time, was selective intercostal reimplantation. And that was done, as Dr. Jacobs has pointed out, with arteriography, but also with somatosensory evoked potentials. But those results were disappointing, to say the least. The OE ratios in those studies were high, running greater than you would expect